I'm pleased to introduce our panel members for today. Our moderator is our AAN president, Dr. James Stevens. Our panelists are Dr. Sarah Benish, Dr. Anil Dhuna, Dr. Elaine Jones, and Dr. Stephen Lewis. Dr. Stevens, I'll turn it over to you.
Great, thank you, Lucy, and wonderful start. I'm going to ask Dr. Benish first to introduce herself and tell us a little bit about her journey in neurology and with the AAN and general neurology. So Sarah, it's over to you.
Thank you. Again, my name's Sarah Benish. I'm a general neurologist. It's nice to not be the only general neurologist on a panel. It's very exciting. I'm at the University of Minnesota currently, where I serve as the division head for general neurology and also the physician chief for the neuroscience service line, which is neurologists, neurosurgeons, spine surgeons, and pain physicians for mHealth Fairview Health System. And I became a general neurologist mainly because I kind of liked everything in neurology. And so when everyone else was picking fellowships, I was like, well, I could do that, but I like this, and I could do that, and I like this. But so I couldn't really decide. And so I decided, well, I don't need to decide. I'll be a general neurologist and I can kind of see it all and sculpt my practice the way I want to. So I just love seeing patients. I love being a help to patients and improving their quality of life. And that's my main goal, is to provide that good quality care. I started my career in private practice. I spent a decade in a physician-owned private practice group and then transitioned to the University of Minnesota to become involved in kind of that health system approach to quality care, not just in a single specialty practice, but that's truly my passion. And I gained a lot of that passion through work in the AAN. I was in one of their leadership programs and then became involved with the quality committee and launching the Axon registry, which is a quality improvement data registry. And it's through my work in the AAN that I really developed that passion for the processes of helping improve the quality of care for all patients in our health system. And so I think the AAN's been instrumental in sculpting my career. And I will stop talking.
Thanks, Sarah. Wonderful. And Sarah didn't mention it, but that leadership program, she and I were first connected because I had the honor of being her mentor through we called it ELF at the time, but yeah, through the leadership forum, and she's a superstar. I learned so much more just having her and involved in the program. So I'm going to move on to our next panelist, Dr. Anil Dhuna. So Anil, if you'll tell us a bit about yourself.
Well, thank you, Dr. Stevens and the AAN for inviting me. Well, I'm a founding partner for a 5-provider practice in Southeast Iowa. My journey into becoming a general neurologist is kind of unusual. It wasn't expected. I had gone into very much an academic track. I'd done a fellowship in epilepsy and PET imaging, was in research. Then so my real passion was clinical work. And this is the 94 time period, and I wanted to start a practice on my own. I wanted to start from scratch, be the captain of my own ship, and it's from that journey that I've grown. It's become general neurology, but we do a lot of other things. So I think general neurology is not just one area. We have specialty areas in sleep. We have clinical neurophys. So it's been exciting to see these fields develop over these many years. Being a private practice, it was very much focused on building the practice, and I didn't realize how much I'd be engaged and enjoy the actual business part of private practice and involved in growing the practice itself. I became involved in the neurology community through the Iowa Neurological Association. I was the past president and president. This is how the journey started about 12 years ago. And I got to meet my colleagues around the state. We started to become very active in retaining neurologists in our state, because we've had a huge number of retirees leave the neurology field in a situation we've had large rural areas with no neurological care. And it's through the INA that I then became involved with the AAN through the Transforming Leaders program. And it really opened my eyes to what the AAN has done for private practice neurologists and the resources there. And now I've been involved in the education committee for the last 3 years, being the voice for private practice and the education we need from the AAN. So thank you very much.
Oh, thank you, Anil. And the next panelist, it's my pleasure to introduce, is Dr. Elaine Jones. Elaine, you have the floor.
Thank you. I appreciate being here. So I was finishing up my training in neurology at Brown, and I met with a wonderful mentor and Dr. Sidney Lewis, who sat everyone down as they were graduating and said, "So, child, what would you like to do?" He had this wonderful South African accent. And I said, "I don't know. I can't decide. I like it all. I don't know what to do." He's like, "Well, why don't you just do it all then and see what you like, and you can always change later." So I did. I did neurophysiology as a fellowship, and then I went to a community hospital in Rhode Island. And after about 5 years, I was kind of frustrated with the leadership and administration. And I thought, I could probably do this on my own. I had wonderful support from lawyers and business people, friends who were in these fields, and they really encouraged me. So I opened my own solo practice. And as I was doing this, I learned about the Palatucci Advocacy and Leadership Forum at the AAN, and I applied because it sounded interesting. And so I went to the first year of PALF, and from there, it kind of led into being on the Legislative Affairs Committee, and then I chaired the Government Relations Committee. And through that, I got on the board as a chair of a committee. I got involved in the Coding and Payment Policy Committee. I got involved in task forces from the board. And I have to say the AN has been amazing for my professional development. I have enjoyed so much being involved with that side of things, but I still love doing, general neurology. About 5 years ago, I actually closed my practice and started doing teleneurology. I've been working with specialists on call for the past 6 years. I was working with them while I still had my practice, and I like it. It's a great lifestyle, but I miss the longitudinal aspect of taking care of patients. I miss the different problems that come in. I always loved seeing, okay, what's coming in next. So at heart, I'm a general neurologist. I'm still a private practice neurologist, and I hope someday to get back to that. So.
Thank you, Elaine. And that last but not least on our panel, Dr. Steve Lewis. Steve, talk to us about your story.
Thank you, Jim, and thanks for asking me to be on this panel. So I finished my residency, and I think similar to what the others have said, I really didn't have any particular subspecialty interest. At the time when I finished, I felt that a fellowship meant you had an academic interest in something, and you were going to spend the rest of your life doing that and doing research in that. And I just didn't have that interest. So I went right into, I did not do a fellowship. I went right into private practice. I spent the first 8 years in the private practice of general neurology in a 2-hospital system. We were the only neurologists at 2 hospitals in the suburbs of Chicago. I saw lots and lots and lots of patients. I really feel that's where I learned neurology, my 8 years in private practice. So I learned sort of how to be a neurologist in residency, but I learned neurology in my 8 years in private practice. The last couple of years of private practice, the chairman of neurology at the time, who was a general neurologist named Jack Fox, he asked our group, because he had a connection with our group. He actually started our group, so there was an academic connection, if you will, but he asked us to become the general neurologist for Rush. And what that meant initially was spending a day or two staying in private practice, but spending a day or two supervising the residents. So I did that, loved it. And then after a couple of years of that, he said, "You want to come on full time?" And it took me a millisecond to say yes. I left my practice, went full time at Rush, where I spent the next 20 years. Became the residency director, the head of general neurology, and ultimately the associate chairman. It was during that time I started getting involved in the academy, and that was, talking about well-being. Being involved in the academy was just a cure for any well-being issues that anyone has. Just was wonderful. I was involved in education committee, residency things. Ultimately got involved in the Green Journal as one of the section co-editors for continuing medical education, finally became the editor of Continuum. About 4 years ago, was recruited to become the head of neurology at Lehigh Valley Health Network, where I am now. So I'm it's sort of a academic, clinical, community hospital. We have 4 additional hospitals. So it was a very, very large network of hospitals where I'm the chief of neurology. So I'm able to practice general neurology still, administrate a large department, if you will, and it's just been great. So it's again, I really thank the Academy for all the things that I've been involved in, and it's really been terrific. But I wouldn't change anything else. Being a general neurologist, one last comment I want to make is a general neurologist can do anything except give chemotherapy, perform epilepsy surgery, and mechanical thrombectomy. There's nothing we can't do, and it's really been a great ride, and I'll continue to do this for many years. So thanks, Jim.
No, thank you, Steve. And as you can all see, yeah, he just has another little responsibility in the Academy too. If you look behind him with Continuum, and he's the editor-in-chief, and he has done an outstanding job. And that's one of the unbelievable hallmark publications of the Academy that's focused on education and focusing on the latest information in our specialty. So Steve, outstanding job as editor. I'll tell you just briefly about my story is that when I was going through my residency, of course, all of our heroes and heroines were our faculty and our staff. And boy, you tried to look around and say, who do I want to be like? Who do I really want to emulate? And I wasn't sure. I loved it all as well. And that during our final year, we had a lot of elective time. So I chose mine to go out of town and work in neuroimmunology because that was an area that I was somewhat interested in. I worked in a lab in Chicago for several months. And I thought it was interesting, fascinating, but what I did learn through that is that, boy, I've got to get my hands on people. I can't sit there in the lab all day. I said, this is not for me. I'm glad it is for a lot of people, but I said, for me, no, I've got to see people. And so that was a really good lesson for me just to figure out, well, what was it that I really didn't like and what resonated with me. So I left residency and went into a private practice group, and I'm at that same group. This is almost 35 years later. And that it's an interesting group in that we all do comprehensive neurology, but we all have a different subspecialty interest or board certification in a subspecialty, and that we find that we help each other when we have problems in that particular other specialty. But every day, and it's like this morning, I just went in and I got to see patients this morning. I saw someone with myasthenia who had sleep apnea, and I took care of both those problems. I had somebody who came in who had MS and ended up having seizures, probably from one of their MS meds, Empira, helped them with that. Had somebody who came in with migraine headaches the same day. And then I saw a patient with narcolepsy and cataplexy. And this was all in my morning before I started my meetings today. And I think there's nothing better in my book. It's just like, and I tell people, they've heard it before from me. It's Forrest Gump and the box of chocolates. And I open it up every morning. It's like, what am I going to get today? Let's see. So it's easy for me after doing it for this many years to get up every morning. I find doing comprehensive or general neurology a real treat, just an unbelievable, rewarding experience for me. So Lucy, I'm going to kind of turn it over initially and see from the group, now that you've met us all and heard a little bit about our journey in general neurology, I just want to answer some questions.
The first question, Dr. Stevens, is with some of you working in both private practice and at academic centers, what are pros and cons of each?
Great. So I'm going to defer to the two panelists, Dr. Benish first, and then Dr. Lewis to try and answer that. So go ahead, Sarah, you first.
So I think I would say, first of all, I think both are rewarding, and I enjoyed both. I think in private practice, when it's a physician-owned business, there's a lot more independence. You don't want to see patients that day. You don't have to see patients that day. I could rearrange my schedule if, like, my daughter, for example, in kindergarten, they seem to really like 11 a.m. Performances. And it's like, who has time at 11 a.m. to go to a performance? But in private practice, I could really easily change my schedule around. So there was a lot of independence and autonomy in deciding there. I think the downside of that autonomy and independence is there's a burden there. There's boy, boy, I need to work to make sure I can pay all my employees and pay my rent. And so like every time you take a day off, you start thinking like, should I really be taking this day off? Am I relaxing, or should I just go in and see patients? So sometimes you have to work a little harder to find that work-life balance perhaps there. But I learned so much about the business of medicine, which ended up being really interesting. And I think it made me a big advocate for physician leaders in healthcare as well. So I think that's the pros of private practice. My academic life, I feel I'm much closer to students. I always had students when I was in private practice, but I have a closer relationship with the medical students and the neurology residents. And I find that really, really rewarding. And then I'm working in a bigger health system. And so there are just some changes that you can make to healthcare in a bigger health system that I couldn't impact in a standalone neurology private practice. That motivates me and excites me. For some people, they think that that is like a heavy lift that they want nothing to do with. And I 100% understand that on some days too. So I think kind of that motivation for that quality of practice and the education of kind of the people who are coming behind you has been really rewarding in academia.
So I don't have a whole lot to add other than to say, some will be echoing. So private practice, autonomy is there, no question about it, especially if you're a one-person private practice. Once you're having 2, 3, 4 partners, if you will, the autonomy becomes a little bit less. But the autonomy is there, the administrative burden is a lot. I would say the only thing I want to add, which Sarah alluded to, is you can be a clinician educator. That title, I know there's a separate panel devoted to clinician educator, but that's what a lot of us are who are in sort of academic general neurology worlds. We are clinician educators, which just a fancy word for an academic person who doesn't do research. So you know, we're missing that third piece. You know, we can write, we can teach, we can do whatever, but we're not necessarily doing research. So the clinician educator part, which includes, of course, educating residents and fellows, is a big part of academic world, whether it's a place like I'm at now, which is sort of a hospital-owned sort of network, or a classic academic hospital. But great question.
Okay, Lucy.
What are the best and worst parts of being a general neurologist in your experiences? Is there anything you would change about general neurology if you could?
Okay, I'm going to let Elaine take a stab at it first, and then
Sure. Yeah, I like the fact we've all talked about the fact of different things. So you're not just doing one thing over and over again. I think, you know, sometimes the negative is that you're viewed as the dumping ground, especially if you're in a larger group with subspecialists or you have subspecialists in your area. So you often get the kind of unknown, the general pain, the headache, the whatever. Um, I actually like those kind of patients because oftentimes things have been missed. And as a general neurologist, you don't have your blinders on. So sometimes you'll pick up things that others might not be thinking about because they're a MS specialist or they're an epilepsy specialist. So I often found those people I could help a lot, which was very rewarding. And I always had the attitude, I was in a solo practice and I was very busy. I had a lot of patients referred to me. I had a big backlog. So I always had the approach that if I decided it wasn't neurology or it wasn't something I was comfortable handling, that I could hand them off to a specialist. I was in a smaller state in Rhode Island and there were subspecialists. And, but so, you know, I think there are pros and cons to it, but as long as you kind of still define what you do and what you're comfortable with, even within general neurology, there were areas I was less comfortable with as MS has gotten more complicated. You know, I can do basic MS, but if they're getting complicated, they're not responding, or there's some, you know, other medical issues, you know, you can reach out to your subspecialists for help in those cases. So I think those are kind of some of my pros and cons.
yeah, and to follow up, obviously, I think from my earlier comments, you know how much I love seeing the variety of disease states that are in our specialty and trying to help people get answers and treatments that are appropriate. I think what Elaine said is the big fear, and it's what concerns me drives people away from the idea of practicing comprehensive or general neurology is that we've had a real explosion, at least in the past, 30, 40 years when Dr. Lewis and I started to where we are now, as far as it's really segued from the diagnose and adios specialty, that boy, there's a lot of things we can do now. And when I started out in practice, let's say there were 6 anti-seizure medicines or 7 that you really used. Now we have so many, and that you just sit there and go, golly, am I missing out or not doing the right thing? And Elaine was mentioning the same thing with MS. When I started out in MS, I think that we had steroids, and that if they were really bad, you'd get Cytoxan, and that you'd maybe throw some Imuran on top of it. But now we've got over 20, approved agents for people who have MS. So I think that's kind of the challenging thing for a lot of people, and they get intimidated by it. But as Elaine mentioned, if I feel like, at least I'm in a group, so if I feel that, hey, there's something kind of out of my comfort zone, then I'll ask somebody in my group who has that specialty training, hey, what do you think? And maybe shift them over there if it's going to be really complex. Or you can always refer to that subspecialist, and I'm glad they're there. But I would say for 95% of stuff that comes through my office, I feel very confident, very comfortable in handling it. And that I'm always worried about in our specialty that there's going to be patients who are seeing 4 or 5 different neurologists with 4 or 5 different neurologic problems. And I'm thinking that's probably not the way to go long-term to provide real efficient, good healthcare. Yeah. So anything else, Elaine? We'll move on to another question, Lucy.
Sure. Do you find that the residents think the fellowship-trained super specialist lifestyle looks better than the general role? Because by and large, the residents all seem to go through fellowship.
Yeah. So yeah, this is, and I'm going to start and then I'm going to hand it off to the panelists. I mean, this was a real concern, and one of the reasons, many reasons why during my term as president, I formed the General Neurology Task Force, because we were seeing this trend. And that, to be honest, when I started out, perhaps 20% of the graduating residents went into a fellowship training additionally, and that now it's over 90% do. And it's like, why is that? And the other thing that we saw is that when we survey our members, as far as the percentage who identify themselves primarily as a general neurologist or comprehensive neurologist, that percentage has dropped from the high 40s down into the 30s, low 30s type things. Like, why is that? And so I think people get 2 misperceptions, I think. One is that, hey, I'm not marketable anywhere unless I have multiple specialty trainings. Not true, because probably what's in most demand right now are those people who can practice general neurology or comprehensive neurology. That is the most demand, whether you're looking at community neurologies or even in academic centers. They're looking for those people. They really are. And the other thing is, which has happened in my group, you can go ahead and do that training, but still practice general neurology or practice comprehensive neurology, which I found to be a model that's worked in my practice. But I'm going to turn it over then. Steve, I'll let you comment next about the
Thanks. So as I mentioned earlier, when I left, I didn't have an academic interest in a subspecialty, so I didn't do it. I do think nowadays there is a fellowship for general neurology, and I'm not talking about the general neurology fellowships that a few places have, including one that I set up at Rush, but Allison Weathers was the only graduate of that, actually. But in the clinical neurophysiology fellowship, in a classic clinical neurophysiology fellowship, which the best of which in my mind are 6 months EMG, 6 months EEG, or at least reasonably balanced EMG and EEG. That is a great fellowship for a general neurologist. So you're going into it saying, I'm going to be able to do EMGs, read EEGs, really know even more about epilepsy and particularly peripheral nerve disease. So that's a great fellowship. You're not going to become a clinical neurophysiologist when you leave. You're going to become a great general neurologist when you leave. So I think that's a reasonable, if you will, a 4th year of neurology residency for a general neurologist. And just to echo your point, Jim, I hire neurologists. There's a great need everywhere for general neurologists, whether it's a private practice, a large hospital network like mine, or the most academic of academic hospitals, because the over subspecialization of neurology has created many patients, groups of patients who really have no one to see because no one will see that patient with an undifferentiated complaint. So you are very marketable as a general neurologist. In fact, can almost name your own price. Don't tell me when I said that. Thank you.
Great. Okay, Lucy, we have a lot of questions to get to, so we'll just keep moving.
Many of us saw a compensation survey during the first 10 years of practice is that there's more money in private practice versus hospital employment.
Yeah, I'm going to let Sarah start out on this because she's worked in both models and can maybe have a little knowledge.
Yeah, so I think in my private practice setting, I had the potential to make more money. It's a high risk, high reward. It's when you do your retirement strategy, and it's like, how risk tolerant are you, and what percentage are you putting in those stocks that are a bit of a gamble? So in private practice, I had, and I'd be interested in Dr. Dhuna's model, but we had no guarantee. It was, you make what you earn. It's not an RVU, it's a literal dollar amount after you cover your overhead. So I had huge swings that I had no control over. Some of it was, I took a longer vacation, but a lot of it was just like, this primary care doctor retired down the street, and that dried up one of my primary referral sources. So high risk, high reward. Overall, when I look at the 10 years, I averaged with a higher compensation. In academics, I have a guarantee. And then I negotiated a bonus for performance. And I think that is definitely something in the recruitment, and I'll echo Dr. Lewis. I'm recruiting general neurologists too, and community setting, academic setting, like send me emails. I'd be happy to interview you, but we can negotiate if you do think you're going to be more clinically productive than kind of the average subspecialist. We can negotiate in like bonuses for that clinical productivity, because that does pay better than research work and education work. So I think that the academic health systems are learning from private practice, and it might be evening out more in the future.
Okay, Dr. Dhuna, now your turn to comment on your experience.
So it's very different. In the 1990s, I had a very small guarantee just to start the practice and just to get me going. And everything had to be done by that point on my own, by my own equipment, my own software, and start from that situation. It's very different now, because it's very difficult for a neurologist to just open up shop on their own. They really need to join another group. They have loans. It's very hard to go and start that whole process. And majority of the physicians we're recruiting now are very comfortable with a fixed salary or RVU model. They don't want to take a risk. They don't want to have the first year say, what I make, I keep, and then the rest I pay for overheads. They want some sort of guarantee. So a practice has to kind of figure out their financials, what can they bring in neurologists at a fair competitive salary. And those have gone up significantly. The competition to recruit neurologists, general neurologists, is so stiff, especially when academic centers and large groups are putting a large amounts of money in there to try to cover the inpatient service. They want the stroke persons in their service. So it's become more difficult. You can join a group, you can start on a nice fixed salary, but it is a potential to make a large amount of money, but it means hard work. But you can also have a situation in a group where you just be very comfortable with part-time and do the hours you want and be comfortable with that salary. So so I think it's both options in a practice setting.
Great, thank you. Okay, Lucy, next question.
What is the best way to collaborate with subspecialists from the comprehensive neurologist perspective?
Okay, and then go back to Elaine first to talk about that.
Yeah, so I was, as I said, I was in Rhode Island, which is a small state. I had trained at Brown there, the academic center, and then I was in my own solo practice there. And it was interesting when I initially went out into practice. If I had a patient that I was uncomfortable with their treatment, their diagnosis, I would send them kind of for a second opinion, and they would disappear, and I'd never see them again. But I knew everyone there. And so at one point I picked up the phone and I called and I said, what the F? What are you doing? Let's work together on these patients. You guys are busy. It's not like everyone's desperate for work. Neurologists are in demand and we're all overwhelmed. So if you can guide me in treatment and want to send them back, send them back to me. I'll call you again if I need help with it. So it was actually great because we figured out a great collaboration between themselves and myself. And we had, Rhode Island was unique. There were about 6 solo neurologists in private practice. We were all solo, and we all were kind of affiliated with them. And so we were able to work out a very good relationship with them. I think that's the key. We're all busy. And so there's not so much you got to get more and more volume because we got to share the work. And there are patients that I was really good at taking care of, and there were complex patients that they needed to take care of. So I think there are ways to work it out. You have to talk to them and figure it out. It's less competition in some cases. It should be less competition because we're all in such high need these days.
Yeah, thank you. And Dr. Dhuna, I want your perspective on the referral to the subspecialist and any issues with getting patients back.
So yeah, we use the University of Iowa as our referral center. It's a great resource, but their waiting list is long to get in to any of the specialty clinics, sometimes several months to even get in there. And we really have a dialogue that we want to get those patients back. A lot of these patients, when they go there for a second opinion, want to come back. They don't want to drive an hour each time to go to the university for their care. So we try to set up a dialogue. Give me advice what we should do on this patient. It's a complex MS patient. What's the next treatment option? Can we do it locally? Can we do the infusions locally rather than having to go back to the university? So having a dialogue, getting those patients back, the fact that they have to go such a long distance and maybe seeing different providers or residents each time. So I think that they have a relationship with you, they'll come back to you, and you also have a relationship with the specialists as well. So
great, thank you. Okay, Lucy, next.
If you were to go on and practice as a general neurologist, would it be possible to do a fellowship later on? Is this uncommon?
And then I'll tackle it initially because when I came to my practice, I did not have any fellowship training. And the group came to me and they said, Stevens, we think it'd be a good idea if you did sleep. Oh, okay, I'll do sleep. And at that time, there were very few, sleep fellowships. So at the time I went out and I said, you have to give me, economic support to do this. And they certainly did. And so I went to Stanford and then also spent some time at the University of Alabama, Birmingham, and sat for my boards and was able to do that. So is it doable? Sure, it's doable. And I stayed within the practice and was able to come back to the practice and do this. So short answer, yes, it's possible to do that, but you have to be in the situation where you'll get support if you're in a group, or if you're solo, certainly you have to make that call about doing that for yourself. Next question then.
This is a question for Dr. Benish or Dr. Lewis. For more complex patients, do subspecialists at your institution keep these patients or send back to you for long-term follow-up and management? And if so, how do you manage access to new patients?
Okay, so Steve, I'll let you go first, followed by Sarah.
Sure. Similar to what Elaine said. So typically when I send a patient to a subspecialist, let's say an MS expert, I'm usually, or MS specialist, I should say, I'm typically sending it to them because I feel that I'm going to be more comfortable with that decision, or with the follow-up care of that patient being within the subspecialist. So I'm not particularly interested in, say, in following every patient, every MS drug, and making sure that their blood counts are fine and their MRIs are being. So I'm perfectly comfortable when I send a patient to a subspecialist that they frankly keep the patient. These are patients that I really don't want to lose, but I think it's in their best interest that they follow. I'm not as keen on sending a patient to a subspecialist for an opinion, them telling me what to do. I think typically when I send a patient, it's because I think the patient will be better served by that subspecialist. Can I do it? Am I competent to do it? Yes. But I think the patient will be better served by following with that interested subspecialist who has the almost administrative support to follow all those things that need to be done. If it's just a diagnostic second opinion, then certainly they should send the patient back to me. But when it's therapeutic, I would typically keep the patient. So that's my answer.
Great. Thank you, Steve. Sarah, anything to add to that?
Yeah, I do similar things. So I think the answer is sometimes it depends. Like we have some patients who have multiple neurologic needs. And if it's a complex movement disorder patient and they have DBS, I'm out. Like I don't know. So my movement disorder colleagues would be in charge of the DBS, but if they also have gait instability due to their peripheral neuropathy and they have headaches, then I would continue to see them to manage that because my movement disorder colleagues don't have comfort managing that. And we work together as a team to decide who does what. If it's a single diagnosis and I've kind of hit my limit, I often do send on and then discuss with my colleague, like, listen, who has worse access right now? I mean, truly, like there aren't enough neurologists, right? So like, it's like, who can manage this? And we decide together. So I think it's just clear line of communication is always good. And that means picking up the phone and calling or having a face-to-face conversation, putting it inside a note that you kind of expect your colleague to read, I've found in my career doesn't work very well. So I know that we're talking to a bit of a generation that likes texting, but there is definitely a value in a phone call and a face-to-face conversation to sort some of this stuff out that just gets lost in text or email or note format. And so just encourage that part of kind of care coordination.
Yeah, totally agree with that point. It's kind of a lost art, I think, that we actually talk to one another when we're trying to figure things out, but it's very effective if you can do so. Okay, and next, Lucy.
Can any of you comment on neuro hospitals' careers and how that incorporates into a general neurology career?
Okay, now, okay, who wants to take this one? Anybody? Elaine, you're up.
Yeah, so this is interesting. So currently I've been doing kind of different things. I like to do different things with my career. I've been doing some locum tenens jobs, and I have done hospitalist, neurohospitalist. I have done outpatient clinics. I've done outpatient EMG. And I think, I do think being a general neurologist working as a neurohospitalist is valuable for the same reasons we've talked about as outpatient. You see everything. A lot of places now, hospitals have like the stroke team. So some of that high acuity stuff they may take. Some places you're the front line seeing everything. So again, being a general neurologist can be helpful in those situations. Most hospital settings too also have some of the subspecialists around or available. So you can reach out for that backup if you need it. But yeah, I think again, your frontline neurology and the frontline neurologist as a general neurologist can often be the best resource for places.
Yeah, and Dr. Dhuna, do you do hospital work as well as clinic work in your practice?
Yes, so we do both. We have primarily clinic-based, and then we do cover one hospital we work at for inpatient consults. It's just consultation. We don't do admits. We're a drip and ship model. So quality of life is important because I don't really want to be coming at midnight to see a stroke patient, then come to a clinic at 7 or 8 in the morning.
Right.
But what we have, which is nice, is that there's two of us covering we cover 10 days each, but the 10 days we don't cover, we have teleneurology. The hospital covers that now, and that's made our quality of life amazing. I don't do weekends, I don't do holidays, it's done by teleneurology. And that used to be a fight when you have 3 neurologists in the same group, who's going to cover which holiday or not. So that's the new generation is going to be, talking to the hospital, do they have coverage in the evenings, the weekends with teleneurology for if you have an outpatient practice?
Yeah, totally agree. We've gone to a similar model. Absolutely. Next question, Lucy.
Were there financial considerations when you were deciding between private practice and academia? What are the best ways for current residents and fellows to learn about realistic salaries for private practice neurologists?
Okay, Steve, do you want to try?
Realistic salaries for private practice neurologists? I don't know the answer. I would just say be careful what you read. If it's too good to be true, it's probably too good to be true. I'm also going to say something that might be controversial, but I'm going to say it, which is you can't make a whole lot of money in neurology ethically. Okay, a whole lot, whatever that number is, it's very hard to become filthy rich ethically. So just be very, very careful what you read and what those first couple of years guarantees are. So I don't know how, I think the others on the panel may have a better feel of the graph of how these salaries work, but be very careful what you read and what you hear.
Yeah, and that the classic kind of trap, I think that Dr. Lewis is alluding to, is the old kind of bait and switch, and that a lot of people, they will offer something that looks incredible for the first few years, but after that time, all bets are off and that happens not infrequently. So it's do your homework, ask a lot of the right questions, and that I think there is a difference still between pay in the private practice model as well versus the academic center, but it's not as dramatic as it was 30 years ago or 40 years ago. When I came out, there was a big difference, okay, between the two. And there still is a difference, but as was mentioned earlier, it's almost like, what's your spirit like? Is your spirit that, yeah, I'm going to take a little bit of risk here and I like the business, I like being my own boss more than the other, advantages. So it's really what's in your heart that resonates with you that helps you make that decision. But if you're going out and you're seeing something that's eye-popping, and I understand if you've got a lot of debt initially, boy, that looks really, really attractive because that's what you're focused on, is getting rid of your debt. But do a little homework and ask for the long-term questions, I think, are going to be critically important. Next question, Lucy.
Ends meet. Does the typical neurologist need to read EEGs and perform EMGs/NCS studies? What are good ways to master these skills after residency without a formal fellowship?
Okay, and I'm going to go back, okay, to my friend from Iowa, if you want to comment a bit on that one.
I think part of it is our training. We come out of our residency training as great stroke neurologists, but we get less and less exposure to the clinics. And you may only get 3 months exposure to EEG or EMG. So if you're not comfortable at the end of residency, you can consider doing a fellowship. If you don't do it in a fellowship and you go into practice, you can see if you can have a mentor in the practice who could mentor you. Watch over your EEGs, mentor you with EMGs. There's review courses, all those things available to do that. So just try to look at your comfort level, whether you need to do a fellowship or will you work with somebody who could be a mentor to do those things. And those are critical parts of a practice. They may say, we'll only want you as a general neurologist if you can do those things, because they are the money generator for a practice. You can't survive it just on E&Ms, unfortunately, in this day and age.
Can I just add to that, that's actually probably one of the exceptions in academic general neurology. You can actually function without that because we recognize that you're feeding the subspecialists who are performing the EEGs and the EMGs. And so we factor that into your work contract, even though you're not getting those RVUs. I would just say I chose a residency program that enabled me to be competent in EMG and EEG when I left. The NeuroPhys fellowship, as mentioned, is a great solidifier if you're not confident on that. But it's a nice break. It's like, I love my EMG morning. It's great. It's a different way to interact with patients. It's a skill that just adds, again, that variety that we all enjoy. So I encourage people to be kind of the jack of all trades if you're going into general neurology. But for example, I don't read EEG anymore since I joined academia, and I would probably have to do a refresher course if I had to go back to reading that. I just feed my epileptologists who have a much higher level of skill to do that.
Yeah. And then I'll add, yes, in my practice, I read EEGs and do EMGs. Now I gave up doing neonatal EEGs as soon as I got out of my residency. No, I'm not going to pretend to do that. But that's all part of practice. And there's a lot of other ancillary things with practice. There may be some questions about that. So Lucy, why don't we go to the next?
What are the most important questions to ask when interviewing for a general neurology job?
Sure. And that, who wants to take on that one from the panel as far as important questions? Okay, Sarah, I'll let you go first.
Well, I think as we just talked about, you know, those postcards offering those high dollar figures close to a liberal arts college with all amenities for your family. I think you need to understand where the money's coming from. When you're interviewing, you need to understand the basis of your contract, how long it's guaranteed, and what's the work expectation that gets you that salary. I think that's kind of part one. And then part two is to understand kind of what that practice looks like for the other people there, or if you're the first one there, like how you're going to sculpt that practice. So you can kind of mentally try that hat on and see if it fits your work-life balance desires. That would be my main thing. Just ask the questions. Don't be scared to ask something because you think it might not impress them. Ask what you need to know to be able to make an informed decision.
Anyone else?
If I could just add
Yes,
one
please.
other thing, in a typical sort of academic, academic or hospital sort of based practice, I would specifically ask the amount of time allotted to a new patient and a return patient. There's a typical, and I think that every practice might be a little different, but ask that. Be sure it's a number that is, frankly, you're comfortable with, and that you think you could take appropriate care of patients with. So that new versus return, I think, does say something about the practice. And there may be different answers to that and different ways to interpret it, but do know that number.
Yeah. And something that's true in my practice is that I know everyone, when you're coming out of training, the time it takes you to get certain work done is going to be longer. It just is. It's just like, how long did it take you to learn, after you learned how to ride the bike, to get up to riding 20 miles an hour? Well, that takes a little time and a little training, et cetera. And so when people join the practice, we anticipate that they'll take longer. And that over time, just naturally, it's kind of how we do medicine, that your pattern recognition, what's important, not important, you get a lot better at it the more you do it. But Steve's right that when there's production expectations that are way beyond what you feel you're capable for, you, that's not the right fit, and you've got to figure out what the right fit is for you. Okay, Lucy, another question.
What advice do you have to prevent burnout as a general neurologist?
Oh, burnout's a great question. Elaine loves this question, so I'm going to give it starting with Elaine.
Yeah, I think it is a great question, and I definitely got burned out. I mean, there is always this pull between, the more you work, the more you make. And I was in solo practice. If I wasn't working, I wasn't making money. So you can kind of get into that treadmill kind of thing, or the hamster wheel maybe. So I think just stepping back and thinking about what is important. I love to travel. As a solo practitioner, it was difficult to travel, but I found ways to do it. I had great staff that could support when I wasn't there. These days, you can be connected when you're not there. But think about the things that are important to you. If spending time with your family is important, make sure you block off time, maybe 1 weekend, 2 weekends a month, to do that, and just say, you know what, okay, I'm just not making money this weekend. Do the things that you want to do, because you will get burned out, and you will not be a good person, a good doctor. You'll not be good to your patients or your family. So you definitely have to find that time. One of the things that was so important to me was exercise. I got into running, and I did half marathons, and it was kind of like my excuse. Oh, I got to go run. I got this race scheduled in a couple months, So So yeah, you have to remember to take that time for yourself, whatever it is that's important to you, and accept that balance.
Yeah, great answer. And I'm just going to put a plug, shameless plug here. Getting involved with the AAN, I tell you what, is a great antidote to burnout. And that I found that throughout my career, just getting to meet so many interesting people, think about topics that are totally away from what you do day to day. It's really rejuvenating and fascinating. And in getting involved, you'll see that you'll be making a difference, kind of the difference Sarah was alluding to as well, on a bigger scale for your profession. It's definitely an antidote for burnout for me and several on this call. Next question, Lucy.
This one is directed to Dr. Lewis. If you could do it again, would you do a fellowship straight out of residency?
I guess that's for me. So if clinical neurophysiology existed as a fellowship option when I graduated, I would. In retrospect, I'm glad I didn't prospectively, but I do think it is a great way to become particularly adept at those things that just make you even a more marketable general neurologist. But again, as Sarah said, you can be a great general neurologist at particularly an academic or a multi-specialty sort of practice and not do EMG or EEG. So again, I'm not sure, but it would have definitely made me a better EMG or an EEG than I was in practice. And I did do them without a fellowship, to be honest.
Oh, you're on mute, Dr. Stevens.
Next question, sorry.
Sure. I think we may have addressed this, but do you think the yearly decreasing reimbursements in neurology a concern for general neurology practitioner, especially for people planning to go into private practice?
Okay, I'm going to let Dr. Dhuna tackle this question. Go ahead, Anil.
The decreased reimbursement, is that the question?
Yeah.
I think it's going to affect everybody. And sometimes if you, and I think a solo neurologist is very vulnerable, but if they're in a group where there's like 3 or 4 neurologists, they can weather a lot of changes. They can change their overheads, the way they do the practice. So I think it's going to affect everybody when reimbursements come down. Solo practices will be very hard because they have very little way to change income. Larger groups will be able to handle it. And what we've done is we've changed things. We've added in mid-levels to our practice, AVPs, who actually have been able to extend our reach, provide services, and help with the overhead. So there are things we can do to still counter those.
Great. Okay, Lucy.
Yep, the variety and pace of general outpatient neurology is fun and interesting. I worry though that anything could walk in my door and I might not have sufficient expertise in that area. How do you address situations like this?
Okay, anyone want to take that one? Elaine?
I'll take it.
Oh, Sarah, go for it, Sarah.
I think you have to acknowledge you're right. Anything can walk in your door, and that is the joy of general neurology. You have to check the ego at the door as well and be honest with the patient when you say, I'm going to need to phone a friend here. And that's where your tertiary care centers, subspecialty colleagues, other specialists, endocrinologists and rheumatologists, like the community can help you. And another plug for AAN, you've got a tough case, you can pop it into Synapse and ask someone. I mean, there is such a big community, the Women in Neurology community on Facebook. People ask questions all the time. I think you get into trouble if your ego stops you from acknowledging it when you're not quite sure or you're in over your head.
Yeah, and I'd also like to say the beauty of our, especially in all of medicine, is humbling, and it's good to stay humble in it. But that sometimes when you see the patient, you know what, you don't have the answer that day, but you have a plan on how you're going to explore and how you're going to hopefully find things. And we all know in medicine that sometimes things are quite obvious when they walk in, but there are other things that really aren't along the spectrum of classical presentations that take time to evolve and take time. And so those patients sometimes, and I've had patients where I'm just going to see you back in X amount of time. I want to reassess this, et cetera, because I don't have the answer right away. So don't be afraid of that necessarily. I think we all are afraid of, hey, we're going to miss something where the outcome is going to be awful because I missed it, you know. But if you're that kind of person, the odds of that happening are going to be pretty small because you're that kind of person.
And patients don't mind when you say, I'm not sure, but let's work on this together. Don't
Yeah.
abandon them. Don't make them feel lost or helpless.
Right.
They don't mind if you say, I'm not sure, I'm going to reach out, or I'm going to look into this, or we're going to follow it over time.
Okay, Lucy, we may have time for one more.
Can you comment on the role nurse practitioners in your practice? Are you comfortable with them seeing every new patient? Do you supervise them?
So Dr. Dhuna, I know you mentioned it before in your practice. Why don't you tackle this one?
So we started with a nurse practitioner about 10 to 12 years ago, and we started to plug that person into just seeing patients with us, and general neurology is overwhelming. So what we've changed our model to now is that most nurse practitioners have a good family practice background, internal medicine background. They're comfortable with certain diagnoses. The ones we've kind of found that they kind of gravitate to is migraines, dementia, and sleep apnea. They're part of our practice. So they're able to see those patients primarily and on follow-up. If we have somebody in our practice who's stable epilepsy, stable neuropathy, we'll give them as a follow-up. But I would not start nurse practitioners seeing new Parkinson's patients, new MS patients. They may develop that if they're in a specialty clinic where they work with a specialist, and over time develop their expertise in their specialty. So, but starting off small number of diagnoses they're comfortable with, building their experience, the education, then they can branch off to other areas later.
Yeah, thank you. Thank you for that answer. I have to say I'm sad because our time is up for this evening, but I want to thank this excellent panel for giving of their time and of their experience to the audience, and thank the audience for great questions. We didn't get to all of them, and I apologize, but I hope you continue your enthusiasm for our specialty, and whichever route you choose to go. Yeah, you're all in the neurology tribe. You're one of us. And thanks everybody for your attention. Have a good rest of your meeting.
Thank you.
Thank
Thank
you.
you.
Yep. Bye-bye.
Bye.